Now, let's talk about another very important topic is carcinoma of the breast or malignant disorders of the breast. Now, see here. Regarding the epidemiology of carcinoma of the breast, okay, a woman has a 1/8 chance of developing breast cancer at some point in her life. Now, see this. This is a fraction. 1/8 chance is a fraction. And if we talk according to the percentage, it is 12.5%. So this is already a big percentage or big chance of developing breast cancer at some point in her life. Okay. An increased incidence of 1% each year is partly related to early detection these days. Now, these days, because of the advancement in clinical medicine and surgery, because of the advancement in investigation and all things, because people are educated, okay, they know how to, do the self-examination of the breast. They have a quick access to the medical service. So diagnosis has been done quite early, okay. So that may be the reason for increased incidence these days. The mortality rate decreases significantly in the last decade because of advancement in treatment. Okay, different type of treatments are available in case of breast cancer. First is surgery, second is radiotherapy, third is chemotherapy, and fourth is hormonal therapy. Okay, we'll talk about that. So if the diagnosis is done in time, then we can treat her quite effectively. But having said that, if there is a metastasis occurred everywhere, if she comes in very advanced stage, then nothing can be done. Now, what are the risk factors of carcinoma of the breast? See this. Family history is one of the very important point we need to ask. Family history, okay? And regarding the family history, there is 2 to 3 times higher risk, okay, in the family. Means if mother is having breast cancer, then her daughter, okay, is having 2 to 3 times more risk of developing breast cancer than general population. So if first degree relatives, that is mother, daughter, or sister, are affected, the risk is very high. Okay. So if she has developed premenopausal breast cancer, then the risk is very high. Postmenopausal lady can also develop breast cancer. Another very important point is there is presence of breast cancer gene. This is known as BRCA gene, okay, breast cancer gene. And there are 2 types, BRCA1 and BRCA2. BRCA1, there is 60 to 80% lifetime risk of development of breast cancer, whereas BRCA2 is 30 to 80% lifetime risk. So clear-cut increased risk in BRCA1. So what does that mean? In case of family history, okay, the person is or the person may be carrying this particular gene inside them, especially the females I'm talking about here, okay? So before they develop the signs and symptoms of breast cancer, whether this gene is present in them or not, we can test that. We can test that these days. And if these genes are present, then they know there's a high chance of development of subsequent breast cancer. Okay, so this is a very important point regarding carcinoma of the breast. Another risk factor is prior contralateral breast cancer, and this doubles the patient risk. Okay, like for example, breast cancer in some another breast, it just doubles the risk. What are the other risk factor here? Okay, high socioeconomic status. Now, most of the time we are talking about low socioeconomic status as the cause of different type of diseases, but here we are talking about high socioeconomic status as the cause of breast cancer. And there are multiple reasons for that. One is obesity. Okay, obesity is strongly associated with the development of breast cancer. Now, how we explain that? High socioeconomic status may lead to obesity, but not universally. Okay, please don't judge like that. If the person is well aware of the status of the health, then they can maintain their health. So, but there is more chance, okay, of obesity. Now, what do you mean by aromatization of the enzyme, aromatization reaction? Anybody?
Sir, sir, aromatization is a reaction in which androgen convert into the estrogen. Sir.
Estrogen. Androgen in the from the thicker external cells converted into the estrogen.
Very good. Both of you are absolutely correct.
Also, sir,
Yes,
it take place in the adipose tissues.
exactly, exactly. Now, absolutely correct explanation. In case of obesity, there is excessive adipose tissue or fatty tissue everywhere. So that androgen, okay, which is present inside the female body as well, it may convert into estrogen, okay, and that excessive estrogen may be responsible for carcinoma of the breast. That is the hypothesis they are explaining here, okay. Nulliparous women's risk is 2 to 3 times than the general population. Nulliparous means she never gave birth to a baby. She never, okay, gave birth to a baby. Nulliparous. Now, if that is the case, then there is increase unopposed level of estrogen. Okay, increase unopposed level of estrogen, which may be responsible. And another point, if there is early menarche and late menopause, now listen here, early menarche and late menopause is also associated with the development of breast cancer. Now see this, just to justify this, the risk is lowest in women who become pregnant before 23 years of age. So this pregnancy is protective against development of breast cancer. And if she is nulliparous, there is more chance. Exogenous estrogen has been shown to increase the risk of breast cancer in postmenopausal women as well, because sometimes we need to prescribe this estrogen just to counter the effects of menopause. Okay, so that is just increasing risk there. But one important point I like to highlight here is, if we combine estrogen and progesterone, the risk is not that very high. Okay, if we combine progesterone along with estrogen, it will probably counteract the effect of estrogen there. Let's move on. Now, this is one slide, okay, which is including some further information regarding the risk factors of breast cancer, and many of them are not a direct type of risk factor. They may produce something else first and then which may lead to breast cancer. And remember, that's why these are called risk factors. Risk factors and cause are a bit different. Cause means it's proven. Cause means it's proven, and risk factors means they may lead to that condition. It's a bit of suspected thing, a bit of hypothesized thing. That's why in many of the cancer, you must have noticed, if it is a very clear cut type of thing, we write cause. Otherwise, we discuss like a risk factor. So it is hereditary, lifestyle, okay, smoking and alcohol are also associated with the development of breast cancer. Different literature has mentioned that. Age, more the age, okay, higher the chance of development of breast cancer, okay, rather than the younger woman. Obesity, already talked about. Pregnancy and breastfeeding, there is a chance also. Diabetes, okay, probably not directly, but diabetic people may be obese, or you can also talk like that. In obesity, there is a high chance of development of type 2 diabetes. Essential hypertension, probably not directly related again. In obesity, there is a high chance of hypertension. and even diabetes also, and hormones. These are the exogenous hormone which we give from outside. Okay, all the symptoms and things like that we'll talk later on. Now, these genes, let's talk a bit again. Look at the names of the gene which are strongly in connection with the development of breast cancer: BRCA1, BRCA2, and Lee-Fraumeni syndrome. Now, some of those terms are quite familiar to you before. Now, BRCA gene, okay, it is present on chromosome number 17. It is associated with ovarian cancer, endometrial cancer, prostate cancer, and colon cancer. Okay, and it is definitely more aggressive than the BRCA2, and there is more chance of development of breast cancer in this case, up to 80%. BRCA2, the chromosome is present in number 13. Okay, the affected gene, I should say, is present in chromosome number 13, and it is associated with male breast cancer in 6% of the cases, ovarian in a bit less, prostate, colon, even melanoma, stomach cancer, pancreas cancer, and biliary cancer. Now, what is melanoma?
Melanocyte producing cancer.
So it is a skin cancer rising from the melanocytes which produce the melanin for the pigmentation of skin cell.
Very good. This is a type of skin cancer. Excellent. Okay. These are the skin cancer. These are the most serious type of skin cancer. If your teacher asks you, can you name some of the skin cancer? This is a very easy or important question. That is squamous cell carcinoma of the skin, basal cell carcinoma of the skin, and melanoma. Now, among them, the basal cell carcinoma is the most common one. Okay, and melanoma is the most malignant one. Melanoma may kill the patient because of extensive metastasis, whereas basal cell carcinoma and squamous cell carcinoma, do not usually cause mortality. Now, these BRCA1 and BRCA2 genes are actually tumor suppressor gene. Okay, I'm sure you know the meaning of that. Tumor suppressor gene means they don't allow, okay, the development of malignancy or the tumor in the body. But once they are mutated, okay, once their structure change, then okay, they cannot stop development of different type of neoplasm. Okay, never forget this. So similarly, we have a situation known as Lee-Fraumeni syndrome. Okay, this is caused by mutation in another important type of tumor suppressor gene known as P53. Okay, Lee-Fraumeni syndrome, and in this condition, the person may develop different types of cancers in the body, like leukemia, like osteosarcoma, brain cancer, and adrenal cancer, along with breast cancer. Okay, breast cancer is common in all of them. Okay, along with breast cancer, these are seen. Please understand like that. So this is a role of gene, in the causation of breast cancer. So let me repeat again before we go for the break. Anybody who is having breast cancer in the family, the other family members should be going for the examination of this gene. Now, this is the summarized slide of a different type of risk factor. Okay, before we move further, let's talk about that once again. The family history, very important point. Mutation of the gene, BRCA1, BRCA2 mutation, P53 gene mutation, important factor. Late childbearing, okay, late childbearing, because there is a excessive unopposed effect of estrogen. Early menstruation and late menopause, see this, as well as obesity, already talked about. Increased breast density, which is found by mammogram. Prolonged use of oral contraceptive pills. Hormone replacement therapy after the menopause has increased chances and risk. And even alcohol intake or tobacco consumption has an increased chance. Okay, so this is a good slide to remember. What are the risk factors or the causes of breast cancer? Now, how breast cancer develop? A bit about the pathogenesis. but this pathogenesis is not different from any other types of cancer, isn't it? See here, in the beginning, there are normal cells. You can clearly see that. But in case of breast, this is a type of gland. This is type of, modified sweat gland actually. So it consists of some glandular tissues, some connective substances or connective tissue, which are stromal component, some fatty tissues, okay, duct, and everything are there. So in the duct, there may be hyperplasia. Some of the cells will become atypical, okay, atypical. Then they will convert into ductal carcinoma in situ. In situ means they have not crossed the basement membrane till now. Now, when it crosses the basement membrane, then it becomes invasive cancer. Invasive cancer. Now, in this case, only the ductal carcinoma is shown, but there are different types of breast cancer, like lobular cancer also. Okay, like a medullary cancer, different types are there. But the most common one is a ductal cancer, so that's why it is nicely shown here. So these are the different steps. Now see there, the same thing is shown here. Once again, hyperplasia of the duct, atypical hyperplasia, then in situ, okay, then microinvasion, then invasive type of ductal cancer, and after that it can metastasize anywhere. Now, after knowing that, let's talk about how the patient present. What are the symptoms and sign, or what we get during physical examination? Very, very important part of this lecture. Now, one of the most common type of presentation is a presence of a mass inside the breast. Okay, this is the presenting symptom in almost 85% of the patient with breast cancer. It's a very common type of presentation. Now, see there. So how they find out that there is a mass? So I already told you, many of the patients, if they are well aware of their health, they know how to self-examine the breast, and during that process, they find out there is a mass there. And some other women probably find out the mass when it is too big, when there is some discharge from the nipple, okay, when there is pain in that area, when there is some asymmetry of the breast, something like that, they may notice it. Pain is rarely a symptom, but should be completely evaluated to eliminate the possibility of malignancy. So pain is not a common symptom of breast cancer, okay? But when there is a complaint of pain in the breast and she comes to the hospital because of that, we definitely want to take a good history and then do different type of investigation. And that will definitely rule out malignancy if it is there. So these are the breast cancer symptoms: lump or mass in the breast. And the common site for it is outer and upper quadrant of the breast. Outer and upper quadrant of the breast. Now, what is that? Outer and upper quadrant of the breast. See here. So if I draw one vertical line from here, okay, like this, and if I draw another horizontal line like this, okay, now the breast is divided into 4 quadrants. So this quadrant, this particular one, is upper and outer towards the axilla. Okay, this is upper and inner, this is lower and outer, and this is lower and inner. So that is the way. The second is pulled in nipple. Okay, pulled in nipple, or retracted nipple. This is known as retraction of the nipple. It's a very important symptom in case of breast cancer. The third is called dimpling. Okay, dimpling. Dimpling means one particular area of the breast is pulled inside. It's like a puckering. Okay, there is indentation formed. This is called dimpling. Everything has got a mechanism. Okay, I'll talk about that. Let me finish this first. Another is a dripping. Dripping means nipple discharge. Okay, nipple discharge. Another symptom may be redness or presence of rash, okay, on the nipple or on the areola or on other some areas of the breast. If it occurs on the areola or around the nipple, then it is known as Paget's disease of the breast. And Paget's disease is one of the marker of underlying malignancy in breast. Okay, and some other skin changes may be there, like some swelling. Okay, some swelling, some redness. So those are some other changes. Now, one small point I like to highlight here. Remember, in surgical anatomy of the breast, okay, I talked about Cooper ligament. Okay, Cooper ligament, and I also talked about some superficial lymphatics and deeper lymphatics. Now, what are those Cooper ligament and what is the importance of that? If you still remember that, yes? Anyone?
Sir, Cooper ligament mainly, sir, attach the breast parenchyma to the chest wall.
Okay, good. So what is the importance of that? For example, he's absolutely
Support
right.
the breast.
Yes, they support the breast.
So
Yes.
the Cooper ligament they maintain the shape and the structure, sir, because they connect the underskin of the breast to the to the outer chest muscle. So, sir, they contain the breast basically.
Exactly, absolutely correct. All of the students are saying the same thing. Very good. So these are the supporting elements. So these are a fibrous cord or fibrous band, okay, or septa, which are extended from the subcutaneous area of the breast anteriorly to the the fascia, which is covering pectoralis major muscle posteriorly, and they support the breast. Now, if the malignant cells from the breast cancer infiltrate those Cooper's ligament or those fibrous band, then there will be some clinical manifestation present in the breast. So dimpling or puckering of the breast, okay, and retraction of the nipple, and all those things may be caused by that mechanism. There may be some other mechanism which are responsible, but that is definitely one of that. And another important symptom is PUD orange appearance. Okay, it is rather sign than the symptom, but that may be complained by the patient sometimes. Now, what is PUD orange appearance? Have you heard this before? PUD orange appearance, anybody? Let me write that first. PUD, okay, D, orange appearance. Now, PUD orange appearance means just peel the orange and look at the orange peel. Okay, how it looks there. It has a bit of dimples, okay, here and there, isn't it? And it looks a little bit swollen, that type of appearance. So this PUD orange appearance is mainly caused by infiltration of the superficial lymphatics by the malignant cell, so that there may not be proper drainage of the lymph from the skin of the breast, and as a result of that, it gets swollen and it develops the appearance of PUD orange. So this may be some of the presentation of breast cancer, and these are again discussed when I move further. Let's move on. Now, sometimes patient may present with metastatic features of the disease, and sometimes they may be the initial symptom. Okay, it depends when the lady comes to the hospital with the problem, isn't it? If she comes late, they may be the only symptom there, and those are affection of the axillary node and distant organ involvement. Now, axillary node are the most important lymph node which drain the breast. So already talked about in yesterday's class. So usually they are enlarged along with breast cancer. But sometimes what happens, in about 2% of the patient with breast cancer, okay, axillary node enlargement occur without any palpable primary breast tumor. So it looks like the breast tumor is not found there, but axillary lymph node is already enlarged. That means, okay, breast tumor is hidden. Okay, it is not that big so that it can be felt. It is present inside, of course, it is there, but we cannot detect it commonly. At the same time, think about the involvement of axillary node by some other disorders. Okay, in that case, definitely in this case, in this type of case, because the breast is not, big, there is no nodularity or no mass inside the breast. So I have to think of many other differential diagnoses why the axillary lymph nodes are enlarged, and some of them may be Hodgkin's disease or Hodgkin's lymphoma, okay, lung cancer, ovarian cancer, pancreatic cancer, and even squamous cell carcinoma of the skin, and even tuberculosis, okay, even some other bacterial infection like that, maybe or should be ruled out. Now, all of these are probably painless enlargement of the lymph node. That's why those infectious diseases are not included here. If the results of all study, including MRI, are negative, a blind mastectomy, that is removal of the breast without evidence of malignancy, may be indicated. I want to add the term maybe here, okay? But before that, we want to do so many investigation. So this is the importance of, examining the axillary node here. Now, another types of metastatic, manifestation is a distant organ involvement, like lung involvement, bone involvement, liver involvement. Okay, so most of the organs in a advanced stage of the breast cancer can be affected. So accordingly, different signs and symptoms may be there in the patient, like low back pain, okay, appearance of some deformity there, spinal cord involvement, isn't it? If it goes inside the brain, it may lead to raised ICP, headache, vomiting, seizure, loss of consciousness. Those are the features which may be developed. If it is going into the liver, then enlargement of the liver, pain in right hypochondriac area, jaundice, okay, all those things may be there. Sometimes patient may be asymptomatic. So if they are high risk patient, that means they have a strong family history or prior history of the breast cancer, then they should be followed closely with mammography and physical examination. Now this high risk patient, this is the term we use often here, high risk means family history is positive, or they are carrying those BRCA gene in them, okay, or they already had breast cancer in one of the breasts, something like that. So we need to be quite vigilant here. Though they are asymptomatic till now, they may develop breast cancer later on. And they should also be advised to practice self breast examination, okay, a commonly used short form when we talk about the breast disorder, self breast examination. So this has to be told to the females if they are not doing it before. Now look at this beautiful picture here. What this picture is telling us, just have a look here, please. Now look at it. This is a breast. Okay, here is areola, and here is the nipple. So this is a mass here. This is a carcinoma of the breast. And from there, these malignant cells are metastasized first into the lymphatics. See this? It is going towards the internal mammary node, which is medially, of course, and from lateral side, it has entered into the axillary group of lymph nodes. The first group of lymph node, which is directly responsible for the lymphatic drainage of that particular organ, okay, is called sentinel node. The sentinel node has got a very important role here. Okay, this term will keep on coming in the subsequent slides. The sentinel node means this is the first node or first group of node which are affected by the malignancy. Means they drain the malignant cells first, and if they are not affected, then there is very less chance that other lymph nodes are affected. That is the meaning of finding sentinel node. And one very important point I like to highlight here is, before the surgeon decides for lymphadenectomy from the axilla, they first will find out whether sentinel node is affected or not. If sentinel node is affected, then they will go for lymphadenectomy of all the lymph nodes here. But if sentinel node itself is not affected, they don't need to go for that. That is the huge importance of finding sentinel node here. Okay, now see this slowly. And sentinel node usually is an anterior group of lymph nodes here. Okay, they are called pectoral nodes. From pectoral they go to the central, and from central they go to the apical, and then ultimately everything is drained into the thoracic duct and then into the venous blood. Now, regarding the initial evaluation of the patient with possible breast disease, okay, this is a bit of revision for you. Complete medical history, including the risk factor for breast cancer, has to be asked. Okay, and be sure to inquire about any history of nipple discharge or any change in the size, shape, symmetry, or contour of the breast, whatever is noted by the patient. Sometimes, they just feel one breast is a bit of different shape than the other because of the big mass inside. Sometimes they may change, nipple is retracted inside, isn't it? So all these things has to be asked to the patient, and then that should be confirmed when you examine the patient. Now, during physical examination, during the examining the patient, what we are going to do. This is a very important class, and this is a bit of clinical as well as theoretical class combined together. Okay, so there are lots of slides I have edited here, so please pay attention. Now, regarding inspection, okay, that's always the first thing to do before palpation. The patient sits and raises her arms upward, then presses on her hips to contract the pectoralis major muscle before we inspect her, before we visualize the breast. This is the position she has to attain. She sits on a chair, okay, raises her arms upward, then presses on her hips to contract the pectoralis major muscle. Then look for the symmetry. Symmetry means exactly it looks same on the both sides. So sometimes it looks slightly bigger on one side than the other. Means there is a mass inside. Okay. Observe her skin changes like color, texture, dimpling, edema, which is known as pudiorange, and ulceration because of the visible tumor. So any type of skin changes, we have to note it. The pudiorange and dimpling are the very, very important point here. And look for the retraction of the nipple as well as discharge from the nipple. Usually, so there may be bloody discharge if it is a cancer inside, but not all the ladies will have that. Okay, only few. And nipple retraction is an important feature of late stage of the breast cancer. Now, what we do during palpation? After inspection, it's a turn for palpation of the breast with the patient in a supine position and with the ipsilateral arm above the head, okay, and a pillow under the ipsilateral shoulder. The physician palpates the breast for masses or asymmetrical density. This is the position we have to maintain in the patient. Ask the patient to lie in a supine position, okay, and with the ipsilateral arm means the affected side above the head and a pillow under the ipsilateral shoulder. Now it makes her comfortable, and we examine the breast and the axilla as well. The axilla and the supraclavicular region should be examined for lymphadenopathy. All four quadrants of the breast should be examined, but the most important quadrant is upper and outer. Even underneath the areola should be palpated because there may be a hidden cancer there, especially in case of Paget's disease of the breast. The nipple areola complex, okay, is squeezed for any type of discharge. Sometimes the bloody discharge or serosanguinous discharge may come out in case of malignancy. So this is about palpation. Now a bit of schematic diagram here. This picture is telling us tumor, okay, may present like that. It's an irregular type of mass in one quadrant of the breast. Other types of breast pathology are also shown here, like fibroadenoma, okay, fibrocystic changes. See this fibrocystic changes, some cyst, okay, some fibrosis together. These are different types of changes. Now, because of this tumor, okay, there is dimpling of the skin, dimpling of the skin. It may be because of the involvement of Cooper's ligament, and PUD orange is because of infiltration of the superficial lymphatics by the malignant cell, so that there is no proper drainage of the very superficial lymphatics. Now, this is the pictorial form of how to examine the breast. Inspection of the breast with arms at side. Okay, this is the way. Those hands should catch the hip on the side, so that pectoralis major muscle is contracted, and then we can nicely inspect. Inspection of the breast with arms raised is another way. Palpation of the breast with the patient supine, just like this. See here, the arm should be moved above the head, and for the proper comfortable position, one pillow has to be kept below this. And then this is the way of palpation of the axilla for the axillary lymph node. Now, some of the picture, okay, we have included this dimpling of the breast. Look at this area here. This area, there is definite dimpling you can feel here. Okay, so this is definitely abnormal type of presentation in the breast. So good examination has to be done if this type of case comes to you, just to rule out the underlying cancer. Now, here is the nipple inversion or inverted nipple. See this? A clear-cut case of inverted nipple. So probably the nipple is pulled inside because of the involvement of those Cooper's ligament, because of the involvement of those lactiferous duct, because of infiltration of the malignant cells. Now, here is nipple inversion with erythema of the breast. Look here, it's a apparent red in appearance along with inverted nipple. Okay. High chance of malignant type of growth inside. Now, this is known as PUD orange. This is a quite typical PUD orange, and look at the symmetry of the breast. Okay, totally different, totally different. And this PUD orange is mainly produced by infiltration of the superficial lymphatic channel by malignant cells to exactly look like orange peel appearance. That's why it is known as PUD orange appearance. Another very close view, see this? Exactly looking the same, orange peel appearance. Very important MCQ question, they will love to ask you, okay? So remember that from the discussion. Now, after we examine the breast, now it is the turn for radiological evaluation. So the first on the list is mammogram or mammography. Okay, mammogram or mammography. Well, let's talk about it. Now, a baseline mammogram has to be done at 40 years of age, and after that every year, okay, even if there are no risk factors present in that lady. But if there are risk factors present, if she belongs to the high risk category, then see here, if the patient has a family history of early breast cancer, the first mammogram should be done 5 years earlier than the age of the family member when diagnosed with breast cancer. And one example is given here. For example, a patient whose sister developed breast cancer at the age of 39. Now, she should have her first mammogram at the age of 34. That means 5 years before her sister developed breast cancer. Now, why is that? The question would come. because there's a high chance she would develop it, and we want to catch it quite early. Okay, that is the reason. And mammogram is a special type of radiological evaluation of the breast. This is the way mammography is done. Okay, in the radiological department. See this? The mammography has been done, and she is looking at the screen at the same time. Okay, this is how a mammographic film looks like. Now see that this is very, very important, so please pay attention. Mammography can reveal the following: the architecture of the breast, means overall appearance of the breast, whether it is distorted or not, symmetry or asymmetry of the breast, skin thickening, irregular masses, and microcalcification. All of these informations are provided by mammography. So this is a normal mammogram. It looks like that. Now see there, this is quite a nice a type of mass which is picked. Okay, so this is a benign cyst, not a cancer. And cancer looks like this, a bit of irregular type of mass. Okay, irregular. And look here, this mass looks quite irregular. Okay, it is a densely white here, but the surrounding area is not that densely white, and a bit of asymmetrical, and architecture of the breast is also a bit distorted. It's not exactly like this. See there, it is distorted a bit. Okay, and sometimes what happens, there are some microcalcification. So see this small dotted like appearance, and these also strongly suggest there may be a chance of malignancy. Now some other picture. This is a malignant lump. Okay, star shaped or very irregular in outline, you can say. These are the microcalcification. They are very magnified view. Okay, see this microcalcification, and this is a very rounded, smooth, regular outline. So this is a benign lump. And still, if doubt exists, then after mammography, we have to go for FNAC, core biopsy, or excisional biopsy. That option is always there. Now, a bit about breast calcification. These calcifications are small calcium deposit. Okay, small calcium deposit in the breast that show up as white spot on a mammogram. Large, round, or well-defined calcifications, which are shown left, this one, okay, are more likely to be non-cancerous, that is benign. And tight clusters of tiny, irregularly shaped calcifications on right may indicate cancer. Okay. Like this, these indicate cancers. There's high chance. Okay. So, what is the lesson learned? Mammography or mammogram is one of the important investigation we order in a suspected case of breast cancer. And to be very, frank, after the age of 40, all women should go for at least one mammography. And if they belong to high risk category, then they should go it every year. And I already explained what is the appropriate time. If one family member is already having it 5 years earlier than she developed breast cancer for the first time, the first mammogram has to be done, and it is repeated every year after that. Now these are the breast cancer quadrant once again. See this. Okay, already talked about that. These are the 4 quadrants: upper and outer, upper and inner. Okay, this is lower and inner, and lower and outer. So there is a 50% chance of occurrence of breast cancer in upper and outer quadrant. Just remember that point. Okay, others are quite variable. And sometimes the malignant mass can develop just beneath the areola. That's why you need to nicely examine the areola along with nipple as well. Okay, this is a normal mammogram, and here is a breast cancer. See this irregular type of architecture. This looks quite smooth here. This is irregular. A bit of speckled type of appearance as well. Now, after mammogram, another type of radiological evaluation is ultrasound, okay, which is also done. But the role of ultrasound is not that important here in comparison to the mammogram or other type of investigation. Ultrasound is important to distinguish whether it is a cystic mass or solid mass. That is important point. So ultrasound is not recommended for routine screening. It is useful as a targeted exam for a symptomatic patient. Okay. And it can further characterize abnormalities seen on mammogram or found on physical exam, like cyst versus solid mass. That's what I was talking right now. And sometimes when we want to do some biopsy, ultrasound guided biopsy, it can be done, because ultrasound will tell us exactly where is the mass, and under the ultrasound guidance we can exactly go there at that site and take out the tissue. So that is another role of ultrasound. Now MRI, okay, magnetic resonance imaging. What's the role of this here? Let's talk about it. MRI is also not used for routine screening. It is a very sensitive but not specific evaluation of the breast. Especially, MRI is useful in the evaluation of patient with mammographically dense breast, patient with axillary disease, and negative mammogram. Mammogram is done already. Okay, the doctor is highly suspecting that there may be a development of the breast cancer, but mammogram is not showing any positive finding. During that situation, we can go for MRI. So MRI can detect the extent of the tumor within the breast and the residual tumor, okay, after lumpectomy, and it can also differentiate between the tumor and post-surgical scar, because the resolution of MRI is much better. So it is mainly done for soft tissue pathology, isn't it? You already know that. So in this situation, MRI can be done, but it is not routinely done for every lady who are suspected to have breast cancer. What's the role of biopsy? Biopsy is necessary to make a confirmatory diagnosis. If a teacher asks, out of all these investigations, which is the gold standard investigation, you should choose biopsy. Okay, biopsy and histopathology. That is the most important gold standard investigation for the confirmation of the diagnosis of any type of tumor or malignancy. Now, biopsy can be obtained by different way. Okay, this is not a new knowledge for you. First is fine needle aspiration. Okay, fine needle aspiration cytology, we say, or you can also call it biopsy. But rather than biopsy, cytology is a better term, because the amount of tissue it obtains is very, very less, and usually they contain cells rather than tissues itself. Another is called core biopsy. Okay, another is definite surgical type of biopsy, means we cut that area and we remove a part of the mass, or we remove the whole mass. So incisional biopsy or excisional biopsy, there are different terms. So let's talk a little bit about that. What is fine needle aspiration cytology? You see there. This C stands for cytology. Okay, a very thin and hollow needle is attached to a syringe to withdraw or aspirate a small amount of tissue from a suspicious area. The needle used for an FNAC is thinner than one used for the blood test. It is even thinner than that. It is inserted in the suspected site, and then we aspirate something from there. It is useful in the evaluation of palpable lesion. Cyst aspiration is both diagnostic as well as therapeutic. Definitely, if cyst is there, it will draw some fluid, and that fluid is sent for cytological analysis. Cyst fluid must be non-bloody. If the fluid is bloody or blood stained, excision is recommended to rule out malignancy. This is called serosanguinous or pure blood. If the lesion is solid, now a fine needle aspiration can extract some cells and which can be examined cytologically in the pathology lab. If cytology reveals atypia, excisional biopsy is recommended. Means the removal of whole mass is recommended after that. But if cytology reveals malignancy, okay, further surgery is necessary, definitely. So these are the important points about FNAC. And remember one thing, if FNAC is negative, it doesn't rule out malignancy. Always remember that. Don't discard the patient if clinically you are suspecting malignancy, but FNAC is negative. Means you go for some other types of biopsy now, like core biopsy. This is the way core biopsy is taken. Core needle biopsy. See this schematic diagram, but a good one. So a thicker type of needle is inserted there, exactly into the mass, and we need to take some tissues from there. So this is a stronger and bigger needle. So core needle biopsy, this is a larger needle, sample breast changes, okay, which is pinpointed by ultrasound or mammogram. We exactly put this larger needle in that area and take something out. Sometimes we need ultrasound, MRI or CT scan to guide the needle, and another way is vacuum assisted core needle biopsy. So these are the different way. See this is a picture. This is the suspected area, for example, okay, and the needle is inserted there and some piece of the tissue is taken. Now another type of biopsy we have is a surgical or open biopsy. This is open biopsy, means we cut that area and take the tissue. In rare cases, surgery is needed to remove all or part of the lump for testing, and this is known as surgical biopsy or open biopsy. There are two types. One is incisional biopsy, another is excisional biopsy. Now the meaning is very easy. Incisional means a small part of that organ is removed, not the entire organ is removed here. Whereas excisional means the entire organ or that entire mass, that entire mass which is suspected is removed. That is excisional. One important point the surgeon has to note here is the surrounding normal breast tissue should also be included in the biopsy. Now, I have told this point so many times in my previous lecture also, because the pathologist needs to compare between the normal looking cells and abnormal looking cells. Then the report would be standard. Otherwise, sometimes there is a in between indeterminate type of cells, and they may wrongly give like it looks normal like that. So it will be a big problem for the patient and the treating doctor as well. So incisional biopsy means removal of only part of the suspicious area, enough to make a diagnosis. Incision, you cut that area and take a small piece of tissue outside. Excisional biopsy removes the entire tumor or abnormal area with or without trying to take out an edge of the normal breast. It depends on the situation actually. So this is excisional biopsy. Now these are the picture which is explaining that incision is given and here is a tumor. Okay, through that incision we take only this much part, for example, only a small piece from here. So this is incisional biopsy, and when you remove the whole mass, this is excisional biopsy. So these are also commonly done, but less common than a core needle biopsy. Now, another type of tissue, okay, we obtain for the confirmation is lymph node biopsy. lymph node biopsy. And axillary group of lymph nodes are the most commonly involved here because they are the principal node which drain the breast. So how many groups of axillary lymph nodes are there? Can you repeat once again? Yes.
Sir, the five group of
Sir,
lymph nodes.
there are 5
Central,
group of nodes, sir.
lateral,
Five
apical,
Interior, lateral, posterior,
interior,
central, apical.
posterior,
That's it.
anterior,
Good.
posterior, central, apical,
Yeah.
or lateral.
Very good. 5. Very good. There are 5 groups of axillary lymph nodes. Excellent. Anterior or pectoral are the most important one. They are called sentinel lymph nodes in most of the cases. Sentinel means those are the node which get the malignant cells for the first time. Okay. If lymph nodes are involved by malignancy, those sentinel node get it for the first time. So they are usually pectoral or anterior group of lymph nodes in case of breast. And from there, other lymph nodes are also connected. Okay, other lymph nodes are also involved after that. Okay, so anterior, then we have lateral, then we have posterior, then we have central, and we have apical. So these are the 5 group of lymph nodes. If the lymph nodes under the arm or axilla are enlarged, a doctor may need to check them for cancer spread. So this is known as lymph node biopsy. We remove that lymph node and examine for the malignant cells. If no lymph nodes are enlarged, okay, even if no lymph nodes are enlarged, the lymph nodes under the arm are usually checked for cancer spread when the breast tumor is removed at surgery. This is known as sentinel lymph node biopsy. There is a special procedure for that. So what they do, it's quite interesting. They inject some substance in that mass, in that suspected area, for example, tumor in this case. Now, which lymph node gets that injected dye-like material? That is the sentinel lymph node. So they can easily take that lymph node out now and analyze it for malignant cells. If malignant cells have already reached there, then all other axillary lymph nodes are also removed. So we presume axillary lymphadenectomy is the must now. But if sentinel lymph node is negative for malignant cells, you don't need to go for total axillary lymphadenectomy. So this is a very clear-cut situation. Let's move on. Now, how to do screening? Okay, screening means, okay, it is like, for example, in a family, the mother has already diagnosed with breast cancer and surgery has been done in her. Now, what is the risk of getting that cancer by daughters or by even her sisters? That is found out by screening. And in the screening, we mainly go for the analysis of BRCA and BRCA1 and 2 gene. Now, average risk patient, the screening should begin at age 40 with annual breast examination and mammography. And in high risk patient, the screening should begin 10 years before the age of diagnosis in the first degree relative. In the last class also we talked about this. 10 years before the age of diagnosis in first degree relative. Okay, so this is the high risk patient, means multiple risk factors are present in that person. For example, strong family history is there, and all those risk factors which we have discussed, most of them are present. This is a high risk case. Average risk patient means, being female itself is a risk factor for the development of breast cancer, isn't it? And obesity itself is a risk factor. See that diabetes, hypertension, they are also correlated there. So every female, this is an important sentence, every female after the age of 40, okay, should undergo a mammogram or mammographic study just to make sure that those pathological developments are not happening there. BRCA1 and BRCA2 gene should be analyzed in high risk cases. Okay, let's move on. Sorry. Now, let's focus on this, small table. This table tells us some important points here. See this. This is American Cancer Society recommendation for breast cancer detection in asymptomatic women. They do not have any symptom, but they are probably in risk group or risk situation. So what should we do? What should we do for the screening purpose? This is the age group 20 to 39, and this is the examination they should do: self-examination of the breast and clinical breast examination by the physician. And this is the frequency, means how often, okay, they need to go for that. Breast self-examination is done monthly, and clinical breast examination is done every 3 years. If she is 40 and older than that age, then breast self-examination every month, clinical breast examination every year, and mammography every year. Okay, so this is the important point here. This is also known as screening method. Now, after knowing all these things, let's talk about what are the types of breast cancer, how we classify it. Okay, this is a bit of pathological discussion now. So breast cancer is roughly divided into two big headings: non-invasive type of carcinoma and invasive carcinoma. Now, let's look at the name here: intraductal carcinoma and lobular carcinoma. In situ, they are non-invasive. Remember, in situ means, what is the meaning of in situ?
That's it, they haven't passed the basement membrane.
Excellent. Okay, that is the meaning, and you all know that because this is one of the stage of cancer development, and they are non-invasive. We know if we detect them in this stage, it almost behaves like a benign tumor. If you completely remove that area, that affected area, then the disease is cured. But the challenge is diagnosis at the time. So intraductal carcinoma and lobular carcinoma in situ and invasive carcinoma now they have crossed the basement membrane and they have involved other tissues. Invasive duct carcinoma, invasive lobular carcinoma, medullary carcinoma, colloid carcinoma, papillary carcinoma, tubular carcinoma, adenoid cystic carcinoma, juvenile or secretory type of carcinoma, inflammatory carcinoma, which has lots of signs of inflammation. And in the breast abscess class also we talked about that. Sometimes it may be confused with cellulitic phase of the breast abscess or even with the breast abscess, and carcinoma with metaplasia. Now among them, invasive ductal carcinoma and invasive lobular carcinoma are very commonly occurring in the population. Okay, so we mainly focus on these two. Others are not common. Now let's look at this, beautiful picture. Here is the nipple. These are the lactiferous duct. Okay, and these are the lobules. Okay, lobules. So this is the basement membrane. These are the basal cells. Okay, these are the epithelial cells. Now, if the malignant cells are already there, but they have not crossed this area, the basement membrane, we call it ductal carcinoma in situ, DCIS, ductal carcinoma in situ, because there is a duct here, and inside the duct, a cancer has developed. This is invasive carcinoma. It's very nicely shown here. Look at these cancer cells. They have invaded this basement membrane. Now we call it invasive carcinoma. And when they go to the surrounding area, they do local invasion already. It is also known as metastatic carcinoma. They are actually the similar type of things. Metastatic means a little bit more severe. It has gone a bit outside than the invasion. So these are the non-invasive breast cancer, ductal carcinoma in situ and lobular carcinoma in situ. They constitute 10% of all types of breast cancer. The diagnosis has increased with early detection through mammography these days. Now, one of the good points regarding this topic is many of the ladies these days, they have heard about breast cancer, especially the educated one. Okay, towards the village side, towards the rural area, they don't care. They don't have that knowledge at all. They don't know anything about breast cancer. If somebody died, they say, okay, yes, probably there are multiple thousand reasons for the death, something like that. They never even try to find it out. But if someone is educated now, these days, especially if a family member has suffered from this problem, the other ladies would be quite aware of the situation. That's why a lot of the breast cancer has been diagnosed earlier, because of this important point. Okay, awareness. And then they also have heard about mammography. Okay, a few weeks ago, one of my relative herself was asking me, should I go for mammography and things like that. But there is no history of breast cancer in the family. So that is the awareness I'm talking about here. The prognosis is good in case of a non-invasive breast cancer because it almost behaves like a benign one, and treatment is aimed at preventing the development of an invasive breast cancer by going for early surgery. Let's move on. Now see this. This is a simplified slide which is telling you the same thing. The concept is again the same. This is ductal carcinoma in situ. See this? This is the lactiferous duct. Okay, these are the other small ducts, and these are the lobules. So involvement of this duct we are talking about now. If it is remaining inside the duct, ductal carcinoma in situ. If it is going outside from the duct, we call it invasive ductal carcinoma or infiltrative ductal carcinoma. Similarly, lobular carcinoma in situ. This is a lobule. So lobular carcinoma in situ, and when it moves out of, we call it invasive lobular carcinoma or infiltrative lobular carcinoma. So another beautiful picture is also showing the same thing, because this is absolutely important knowledge students should have. They should understand how a malignancy behave. Okay, so lobular carcinoma in situ, it has not gone out of this membrane. When it goes out, then it becomes invasive one. Okay, see there, invasive ductal carcinoma in situ, and invasive lobular carcinoma. Very good schematic diagrams. Another one, this is the normal ductal cells, non-invasive one, because they are present only inside the duct, and invasive when they go outside. Okay, so these are the different stages of cancer development. In the beginning, there is a normal duct, then it undergoes hyperplasia. Hyperplasia is followed by atypia. You can call it dysplasia. Okay, and then carcinoma in situ, and then invasive cancer. This type of mechanism we have studied in carcinoma of cervix and any other type of cancer as well. So this is a common pathogenesis or mechanism how cancer develops from the normal cells. A lot of processes are going on, like a mutation, a lot of risk factor hit in this phase, and the normal cells will be mutated, and then only a cancer can develop. Now, ductal carcinoma in situ is confined to the ductal cells, and there is no invasion of the basement membrane, and the risk of metastasis is less than 1%. So this is considered a safe type of malignancy, but remember, it is safe only during that time. Later on, this is not a benign tumor, this is a malignant tumor, so it has potential to invade that area. So it all depends on the time of diagnosis. Regarding the epidemiology, 14 to 44% of all new mammographically detected neoplasms are ductal carcinoma in situ regarding breast cancer. Okay, so this is quite a big percentage, and it's good for the patient because we have diagnosed them quite early. Left untreated, ductal carcinoma in situ will progress to the invasive carcinoma in up to 75% of the cases. And who will do that, isn't it? After diagnosis, we don't left it untreated. But the challenge is, if they do not come to the hospital in this phase, then they'll definitely progress to the advanced stages. Regarding the pathology, there is clonal proliferation of the malignant mammary ductal epithelial cell that doesn't cross the basement membrane. And let me remind once again, malignancy is all about clonal proliferation. Now, what is this? What is the meaning of clonal proliferation? Anybody? Maybe I have discussed this before. Yes. Now let me explain. Clonal proliferation means one cell, okay, will convert into malignant cell first, one, okay, and from that cell, all other cells will be formed. Means it will undergo into rapid division, okay, rapid division, uncontrolled division will be there, and in no time, a lot of other cells will be formed. This is known as clonal proliferation. We have studied this type of pathogenesis in leukemia as well. Leukemia inside the bone marrow, one stem cells will be malignant first, and then from that cell, all other cells will be formed. Now, this is a clinical presentation. There is only mammographic abnormality, that is microcalcification on screening mammogram. And we, in the last class, we talked about this. Remember, rather than a big chunk of calcification, a rounded calcification, a smooth type of calcification, if microcalcifications are there inside the breast, it suggests high chance of cancer. Okay, those rounded, smooth type of calcifications suggest more of a benign type of lesion. Microcalcification suggests more of a malignant type of lesion. Only 1 to 2% of these lesions are palpable in physical exam, so they are usually asymptomatic. They are mainly diagnosed by mammography. That's why mammography is so important, in the screening of breast cancer. After doing that, let's move on to the lobular carcinoma in situ. Let's talk a little bit about that. This is most common in premenopausal women, and 0.5 to 8% of all breast biopsies constitute lobular carcinoma in situ. In 50 to 90% of the cases, it is bilateral. So this is a bit of worrisome point. Both breasts are affected. It is considered a marker for increased risk of breast cancer because it has a high chance of, advancing into the serious stages. And the increased risk is there up to 16 to 25% over the lifetime, or 1% per year. And if we compare or if we discuss it in other way, it is almost 8 to 10 multi times more than that of an age-matched woman. So let me clarify this once again. You are comparing, okay, this lobular carcinoma in situ with another, lady who is normal. For example, if a lot of risk factors are there, then this high, chance of developing lobular carcinoma later on in that female. That is the meaning. Both breasts are at equal risk. Not very important than ductal carcinoma. Remember, the percentage wise, ductal carcinoma is much more common than lobular carcinoma. Regarding the diagnosis, no clinical or mammographic findings are routinely associated with lobular carcinoma in situ. It's a worrisome point. Okay, so if mammography is also not detecting, then how can we find out this in the early phase? Okay, so this is a problem. Incidental finding can occur in breast biopsy performed for other pathology, though, but that is very, very rare. Who will go for breast biopsy without any indication? Like, let's talk like that. Probably sometimes what happens, remember, this lady presents in premenopausal age. In premenopausal age or in the reproductive age, fibrocystic changes in the breast is very common, and that occurs around the menstrual period. Now, somehow, if that lady is too much worried and she's she is continuously telling the surgeon that I want biopsy done to me because I'm very much worried about breast cancer, because one of my distant relative has developed it, something like that, and the surgeon is forced to go for the breast biopsy, and incidentally, this cancer may be diagnosed if it is there, like that. Otherwise, it may be unnoticed. Another interesting type, of condition occurs in the breast. Actually, this is one of the marker of underlying breast cancer. This is known as Paget's disease of the breast. In the earlier class, we talked a little bit about this Paget's disease of the breast. Let's talk in detail about this now. Regarding the epidemiology, it is present in 1 to 3% of all breast cancer. It is associated with ductal carcinoma in situ or invasive ductal carcinoma. So this is the meaning of underlying breast cancer in case of Paget's disease of the breast. The Paget's disease can be seen from outside because it has, caused some of the changes in the nipple, or around the nipple area, like, see this, some eczematous dermatitis of the nipple. Eczema means it looks red. There are some flecks or scale development, and most of the time some discharge may also come from there. But we should not be fooled by this. There is underlying cancer in this situation, and that is very, very important point. Histologically, the vacuolated cells, which are also known as Paget cells, are seen in the epidermis of the nipple. So if you take the biopsy, you can find it out. Now, regarding the diagnosis, there is pruritic and scaly lesion that become erosive or even ulcerative. These are the nipple changes or the changes around the nipple, that means in the areola. Pruritic means itching. Scaly, means eczematous lesion, and in a serious situation they become erosive or ulcerative also. If a biopsy is taken, malignant cells can be seen, and mammography should be performed to look for a mass. So this is how we confirm the diagnosis of Paget's disease of the breast. Now see here, look at this picture. Now have a look here. This type of lesions may develop, which is very clearly visible from outside. The nipple and around the nipple, this area may be affected. So we should not consider this as a simple skin lesion, and we should not be fooled by this appearance. So let me repeat again. This is a marker of underlying malignancy, like ductal carcinoma in situ usually. And this is what these cells are seen. These are called vacuolated cell. Vacuolated cell means there is a large gap present in cytoplasm. Almost looks like a vacuole. See this? Now, this is a very misleading type of picture. It exactly looks like some fungal infection or some dermatitis or eczema. Dry looking, skin on the breast around the nipple. Nipple is also affected here, a little bit retracted nipple actually, along with these lesions. Now, a lot of differential diagnosis can be thought here, like fungal infection. Now, which fungal infection can you think here in this situation? Which type? Anybody? I think this topic was not taught to you. This is a type of dermatophyte, isn't it? This is called ringworm or tinea, right? Tinea. See this? This is, central, a bit of clearing area. So typical of ringworm or dermatophyte. But we should not be fooled by this appearance. Underlying malignancy may be there. So let's go for some of the investigation. And the best one is again mammography. If mammography, tells you something pathological finding, then you can go for biopsy. That is the way. With this, let's enter into the invasive breast cancer. Now, see this invasive breast cancer have got different histological types. Different histological types, but the most important one is a ductal carcinoma, invasive ductal carcinoma. tubular carcinoma, okay, colloid or mucinous carcinoma, and papillary carcinoma. These are favorable histological type. They are favorable, whereas less favorable ones are medullary and invasive lobular cancer, okay, and another one we are still coming a bit later, that is invasive ductal cancer. This medullary cancer, okay, this type involves the lymphocytic infiltration and a well circumscribed lesion. Just the name is important here, okay. Nobody is going to ask you detail regarding that, and it is not very common type of cancer also. Invasive lobular, we already talked about. It develops in the lobule of the breast, and when it invades the basement membrane of the lobules, then it becomes invasive. Okay, it becomes invasive. The prognosis is slightly better than for invasive ductal cancer, and one of the worrisome point is it has a chance of occurrence bilaterally. Now, the least favorable histological type, okay, is inflammatory breast cancer and invasive ductal cancer. So these are the important one from the exam point of view, especially the ductal one. This is the most common. But sometimes this inflammatory breast cancer can also be asked to the student because it is quite commonly confused with cellulitis of the breast or earlier situation of breast abscess. The histology of inflammatory breast cancer involves tumor plugged subepidermal lymphatics. Okay, so they are blocking the lymphatic flow, and as a result of that, there may be swelling in that area. Okay, it may look red, so it almost looks like inflammation there. Prognosis is a 5-year survival rate in approximately 30% only. So this is a poor, prognosis regarding breast cancer. And why the term inflammatory cancer is used? Because there are signs of inflammation present, like warmth, swelling, and pain. Now, till now, what we have learned regarding the invasive breast cancer, they are of different type. The most common one, okay, is invasive ductal carcinoma. Another one may be lobular carcinoma, medullary carcinoma, okay, inflammatory carcinoma. So these are the different types. Some are favorable regarding the prognosis, and some are least favorable regarding the prognosis. And the least favorable one are inflammatory breast cancer and the invasive ductal cancer. Now let's see how it looks. Now this is not difficult for you at this time because you have already done the ductal carcinoma in situ. If this ductal carcinoma in situ, okay, has broken the breast membrane and it has gone outside, we call it infiltrating ductal carcinoma or invasive ductal carcinoma. That's it. Exactly like this one in the picture. This is the most common variety. And if we do the mammography, we can see something that is a cluster of pleomorphic calcification. Okay, usually they are known as microcalcification, with or without a speculated density. So there is a density difference, okay, between the affected area and the normal area because of the calcification. They may include medullary, mucinous, papillary, tubular, and colloid type of carcinoma. Now these are the types of cells which are present in case of ductal cancer. Okay, these are all different type of cells, a different type of histological appearance. One schematic picture or diagram is again included here. So see this, just to make the concept clear for you. Here are the duct. So this is a ductal cancer. If it is gone out of the duct, we call it invasive. It almost looks like this. See this, a crab-like appearance. In pathology textbook, it is written like that. Cancer looks like a crab, isn't it? Exactly like this, crab-like appearance. Now, I was asking this question to you guys, like, what can you see here, isn't it? So you have answered, few of you have correctly answered. Look at this breast. it is completely deformed. Okay? There is no symmetry. This is known as asymmetrical appearance. Okay, number one. Number two, I can see some mass there in this area. Okay, and here also there is a mass, so probably multiple quadrants of the breast are affected. There is some calcification. Okay, calcification is scattered type of calcification. This is calcified areas. Look at the nipple, it is also affected, and this is the involvement of axillary group of lymph nodes, and it is completely eroded. It has developed or converted into ulcer form. So this is a very advanced case of a carcinoma of the breast. Probably prognosis is very, very poor in this lady. Okay, and by appearance, this lady must be older. She's a postmenopausal woman. So whatever you can see, describe accordingly. Do not bias yourself during the description. And later on, after your teacher asks, what can you think about this diagnosis? What is the possibility? Then you can, give your answer. Another type of invasive breast cancer we have already discussed is a lobular carcinoma, invasive type of lobular carcinoma. But regarding the diagnosis, and if we do mammography, sometimes it may not be seen. The changes, those typical mammographic changes may not be seen in case of invasive lobular cancer, and it is usually bilateral.